All right. Hello, everybody. It is nearly 8:30 p.m. my time here in Idaho. So I'm just going to do a quick mic check and a screen check. Let us know in the chat or in the Q&A if you can hear me and see my screen. Perfect. Okay, thank you guys. That lets me know that you can all hear me. All right, so let's get started. We've decided to do a late night session tonight. Hopefully, I caught some of you guys who have to work, who have kids, and we want to be as inclusive as possible. So hopefully, we've caught some of you that are unable to make it to some of the daytime free webinars. So I appreciate you guys all being here. My name is Lauren. I've been a nurse for 12 years. I've been with Archer for the last 3 years. I currently work as an OR night shift nurse on the weekends, which is why I am a little bit better at nights than I am during the day. I'm a lot more awake at this time of the day than I am at 8:30 in the morning. So that's just a little bit about me. I do have Jennifer Bonner here in the chat. She will be answering your questions. So um, use the Q&A for your questions that you might have during the webinar, and use the chat if you need to answer me directly. If I ask you a specific question, go ahead and use the chat. I will also be utilizing what's called Slido. This is a polling software. So if you have your smartphones, you can use them to capture a QR code and send your answer directly to the screen, and we can all see those. So when there is a Slido QR code, I'll show you that and I'll point it out. All right. And be patient with your questions. Sometimes the Q&A does get bogged down a little bit, but we'll get to you as soon as we can if you have a specific question. But just remember that there's only two of us, there's many of you, and it does take us just a little bit. All right. Okay, so tonight's live webinar is on fluids and electrolytes. So let's move forward. I first want to hear from you guys just to test out this QR code and this Slido slide here. Just tell me where you're joining from. Let's just kind of get to know each other a little bit for this webinar. All right, I see Texas and Canada, New York, Calgary, Alberta. You're just north of me. Um, UK, Nepal, wow. Miramar, Florida, Vegas, Ohio, more Texas. Texas is well represented. Edmonton, nice. Brooklyn, Florida, Illinois, Houston, more Texas, Oklahoma, Winnipeg, lots of Canadians. This is awesome. All right, Northern California, Jamaica, Mexico, California, Australia, more Texas, more Australia. All right, awesome. I love that nursing can bring us all together. Um, Unfortunately, the NCLEX is what is really bringing us all together, but it's just nursing in general that is bringing us together. So I am glad that you're all here. I am thankful that we can reach everybody across the globe, and this is awesome. Oh, and lots from the Philippines, Ghana. Wow. All right, long ways away. So thank you guys. France, even. This is amazing. Well, welcome, welcome. All right, so now let's get to know how well you feel about fluid and electrolytes. How do you guys feel about fluid and electrolytes? Just rant, vent right at the slide here. Average. Okay. Meh. Good. Okay. So kind of we're in the middle somewhere, right? We're not great, but we're not totally, where we know nothing, right? So we're somewhere in the middle. So let's try and bump that up a little bit. Let's get from meh to maybe, oh, okay, I understand a little bit better. Let's try and make it so that you guys understand these a little better. So using this Slido, tell me just off the top of your head, what do you guys know about electrolytes? What are they? What are electrolytes? Kind of a nebulous topic, right? What are electrolytes? So potassium is an electrolyte. Good. A lot of them do have inverse relationships with each other. Good. So, like calcium and phosphorus have inverse relationships with each other. Someone said that they help regulate the water balance in our cells. Good. That is exactly what we're going to talk about here in just a little bit. Um, they're minerals in our body fluids. Good. That is a great definition. I see calcium, sodium, magnesium. They help the body stay in homeostasis. Awesome, awesome verbiage there. So you are correct. Electrolytes are going to help our body or keep our body in homeostasis, right? These are the building blocks of life, essentially. So atoms, atoms are the smallest component of matter, and these ions that we call electrolytes, when we talk about them in large amounts in the body, are going to regulate everything from our fluid balance to, muscular control. All of those things are going to help us maintain life. Electrolytes are very, very important in maintaining life and just the world in general. So atoms, and we're going to talk more about ions. Ions are atomic particles that have a charge, right? They're either positive or they're negative based on electrons, right? So these are um, atoms or ions that conduct electricity, right? It's kind of cool to think about that we run on electricity, right? We kind of are our own batteries, how we function. We are basically one walking chemical reaction. So learning electrolytes and fluids and all the interconnected intricacies that go along with these can be fun. It can be interesting if we think about it from a different perspective, right? It's not easy to sit and just memorize lists of signs and symptoms or memorize, what hyponatremia looks like or hypernatremia looks like. But if you think about more generalized terms of what that electrolyte is doing in the body, it will help you understand what those signs and symptoms might be. And then once you have a greater understanding of the information behind these electrolytes, then you won't have to memorize those lists because you'll understand what that electrolyte is doing. So let's talk about sodium first off. So we only have an hour together, so I'm probably not going to get through every single electrolyte. We're going to focus on the really big ones, sodium and potassium. But we're also going to keep in mind, be talking about chloride when we're talking about sodium, because sodium and chloride go together. So when we talk about sodium, you can't really separate chloride because in the body, they stay together. And we have to talk a little bit about chemistry here. And I apologize. I know I heard probably like a collective groan when I said that, but we have to talk a little bit of chemistry here. And I used to be a chemistry tutor, so this makes me excited because I'm a nerd, but I love it. So with our ions, like I said earlier, they have a positive or a negative charge depending on what are called valence electrons. You don't really need to know that for the NCLEX. Just, be aware that these are going to have positive and negative charges, right? These are ions. So sodium has a positive charge, and that's how it's typically found in nature. Chloride typically or just naturally has a negative charge because it gains an electron, and sodium likes to give one up based on their valence electrons. If any of you remember back to like high school chemistry and drawing all your, electron clouds and things like that, you probably this is, ringing some bells. But the point of it all is that a lot of times these will bond together. So most electrolytes are not found alone or just, by themselves. They are usually connected with something else, like sodium and chloride are typically together. We also have a lot of things like hydrogen and chloride that often go together. That creates hydrochloric acid. So your stomach is full of hydrogen ions and chloride ions. This is why when we give a proton pump inhibitor, anybody know what a proton pump inhibitor is or can give me an example of a proton pump inhibitor? Throw me your answers in the chat. Omeprazole, good. So Prilosec, yep, is the brand name. Pantoprazole, Protonix, good, good. So those are all proton pump inhibitors. Why are they called proton pump inhibitors? Because hydrogen ions have one proton, right? So they are inhibiting hydrogen ions from collecting and being secreted and combining with chloride to create hydrochloric acid. So that is how they reduce acid in the body. So all of that said, that's just a little bit of, back chemistry to just talk about ions. Your proton pump inhibitors don't really have anything to do with sodium at this point, but I just wanted to illustrate that point that there are a lot of electrolytes in the body, but they rarely sit by themselves. Now, sodium. So let's get back to talking about sodium. Sodium is super, super, super important in our neurological function. And why is that? It's because all of our cell membranes are made up of these lipophilic and hydrophilic uh, components where we have kind of these they look like little jellyfish to me, but our cell membranes are made up of all of these little components and they are semi-permeable. So things can get through only in certain situations or when the membrane allows them to. And in the middle of our cell membranes, we have sodium potassium pumps. And these are found in virtually every cell in the body in any living creature. So sodium potassium are just uber, uber important because we have these sodium potassium pumps. When we get electrical impulses called action potentials that come along our cell membranes, sodium and potassium switch places. So they switch places at a ratio of 3 to 2. That doesn't really matter for our purposes. Just remember that they switch places and they create an electrical gradient. And this is how we relay electricity in the body along our cell membranes is 3 sodium ions and 2 potassium ions switch places and they create that electrical gradient. And we move and then our muscles contract or our brain is able to send signals. That is how electricity is conducted in the body. This is also really, really important because this also stimulates the production of ATP, which is how our body creates energy. So that's a very, very simplistic way of putting it all, but electrolytes are essential for electrical impulses, creating energy in the body, and all of that leads to your nerves being able to function, your muscles being able to function, your brain, everything. Everything relies on these electrolytes. I cannot overstate the importance of these electrolytes. So when they get out of balance, we're going to have a lot of issues, especially in our nerves and muscle cells when we're talking about sodium. So when we are talking about hypo or hypernatremia, we're going to see a ton of neurological problems. When we talk about potassium, we're going to focus on the heart, but you can still see some neurological changes with potassium as well because of the sodium potassium pumps. And always remember that the heart is a muscle. So any muscle in the body can be affected by sodium and potassium. Your heart, um, your bowels have, muscular rings that create peristalsis. Your diaphragm is a muscle, a respiratory muscle. So all of those muscles that rely on those electrical impulses to work properly are going to get off kilter when our levels are not normal. So we also need to talk about water with sodium primarily. So remember, our bodies are about 60% water, right? So it is vital that our water stays in the right places. We need a lot of it in the intravascular space so that we have blood to circulate. And we need water in our tissues so we don't dry out. And we need water in the bowels to move things along. Water is incredibly important. If we are 60% water, it's a huge deal that it stays in the right places. And sodium is mainly responsible for that. Sodium is what we call the most abundant extracellular cation. So that means it likes to stay in primarily the blood and the interstitial spaces. It's not in the cells. It is typically outside. That's why our sodium levels are a lot bigger than our potassium levels in the blood and our other electrolyte levels, 135 to 145. By contrast, our potassium levels are somewhere between, 3.5 and 5. So much, much more sodium than potassium in the blood. We can't really measure exactly how much, sodium is in the cells. We kind of have to stick with what is in the blood. So it is the most abundant extracellular cation. Cation just means it has a positive charge, right? So all of these little sodium particles have a positive charge. This is going to draw water into the bloodstream. Water likes a party. Water likes to crash parties. So if the party, the sodium party, is going on in the blood, that's where the water is going to be. If suddenly we get dehydrated or we lose sodium and there's more of a party going on in the cells and out here or in the brain, that's where water is going to leave and it's going to go into the cells. It's going to cause swelling, cerebral edema, and things like that. And if it goes into the interstitial spaces, you're going to get third spacing. You're going to get things like blisters and ascites and stuff like that. So that's more of your third spacing when it goes not inside the cells, but it's not in the bloodstream and it is elsewhere. All right, so I've seen a few questions in the chat about cerebral edema. We're going to talk about that. We're going to talk about that really extensively here in just a little bit, so hold on. All right, and then as we talk about sodium, I want you to also be inserting chloride because sodium and chloride are typically together. So keep that in mind. They're typically going to be together in the blood and in body tissues. So if you have a chloride imbalance, you probably have a sodium imbalance and vice versa. So keep that in mind as we talk through these. All right, so let's ask a question so I don't just drone on forever. But what are some things that you guys know of that can cause hyponatremia? That would be sodium levels less than 135. What do you guys think? So sweating, dehydration, good. Fluid overload, so we can dilute our sodium levels. I see SIDH. SIDH can cause that fluid overload or fluid retention that dilutes the sodium. Diarrhea, vomiting, those are really big ones that are going to cause dehydration. I see burns. So burns can lead to a loss of fluid, hypovolemia, hyponatremia. Good. Um, let's see. NG tube suctioning, awesome. So if you suction too much, too much stomach contents, then you're going to lose electrolytes. Good. So most of your hyper and hypo conditions can be split right down the middle into loss or retention, right? When we're losing fluid, when we're vomiting, we've got diarrhea, we're losing things, then we get low levels of electrolytes. Or if we're not eating, if you have an anorexic patient or someone who is malnourished, those are going to make you lose electrolytes. Your body's using them up, they're getting peed out, you're losing them. So always think loss or gain as far as electrolytes go. So you guys are throwing out some just great ideas here as far as things that cause hyponatremia. So some of these are times where we've diluted our sodium, right? Our water level has just gotten too high. And some of these we've lost both water and sodium. So we have to know what water is doing in order to know what sodium is doing. So let's talk about this. Great answers, guys. Thank you. All right, so this is the only electrolyte that we really, other than chloride, that we really have to worry about what the water is doing in order to say what the cause might be. The rest of the electrolytes are not so heavily dependent on the water levels, nor do they control the water levels as much. So sodium has a little bit more to it than some of the other electrolytes as far as problems that you can see. So there are 3 different types of hyponatremia because we like to make things complicated for you. But euvolemic hyponatremia, the prefix "eu" means good or normal. So in this case, we have a normal volume of water, or our water in the body has increased, but only slightly, but our sodium level has stayed the same. And so we have diluted our sodium because our water increased, but our water did not increase to the point of hypervolemia, which is what we'll talk about next. So things like SIADH, syndrome of inappropriate antidiuretic hormone. This is a pituitary problem for the most part, where we secrete too much antidiuretic hormone and we retain water. But according to the textbook, it is a euvolemic condition, at least at the very beginning. So this makes us retain water, we dilute our sodium levels, we push apart those sodium particles, and even though the sodium stayed the same, on a blood test, it will show low sodium levels because the The sample's diluted. Your blood is diluted. You can also see this with adrenal insufficiency and Addison's disease, but Addison's disease will eventually lead to an Addisonian crisis and it can cause hypovolemic hyponatremia. So keep in mind that it does depend on where you are in that situation. And we'll talk about hypovolemic hyponatremia in just a minute. We also can have things like polydipsia, where you drink too much, it dilutes your blood down to the point where you become euvolemic hyponatremic. But if you get to the point of water intoxication, then you become hypervolemic. So you have to know what the volume of the body, of the water in the body is doing in order to say which of these three hyponatremias they are in. We can also give too much hypotonic IV fluid. We can not eat enough sodium. Sometimes you see that, especially in elderly people who just kind of aren't eating a very good diet, who are just drinking a lot of water or teas or things that don't have much sodium in them. You can sometimes see that. And then I didn't really explain Addison's very well. So always remember Addison's, they don't have enough steroids. It's adrenal insufficiency, so they don't retain water and sodium. So that's how they become hyponatremic. And then hypervolemic hyponatremia, this is where you really, really have to know their lab values in order to say where they're at, because sometimes these can flip the script and sometimes these can cause hypernatremia, like kidney failure sometimes causes hypernatremia. But if we just are retaining water and they haven't retained sodium or the sodium levels have remained the same, then these conditions will dilute the sodium. But as a general rule, they will have to give you some labs in order to know that they are low in sodium because these won't always cause hyponatremia. So that's a word of warning. So things like congestive heart failure, where they have too much fluid in the body and it dilutes their sodium. Those are types of things that can cause hypervolemic hyponatremia. And things like the water intoxication we talked about, or liver failure, or anything that makes you retain water. All right, so those two are difficult ones to master, but the ones that are most frequently seen, or the type that's most frequently seen, is hypovolemic hyponatremia. So usually you lose water and sodium at the same time. Typically, other than those kind of rare conditions like SIDH, sometimes the Addisons, those are going to cause discrepancies in the water and the sodium. But typically, when you lose sodium, you're also losing water at the same time. So vomiting, diarrhea, oversuctioning on an NG tube, if you set it to continuous and it needed to be intermittent, and it goes on for hours, those are things that can cause hypovolemic hyponatremia. Diuretics. Diuretics will make you pee out fluids and electrolytes. Typically, sodium and potassium are the two that get affected by diuretics, but you can also have diuretics affect things like calcium and magnesium as well. But usually, sodium and potassium are the two that we really think about. Burns cause hypovolemic hyponatremia because they burn off the protective layer of skin. You lose fluids, things third space into interstitial tissues. You get blistering and things like that. So that can cause hypovolemic hyponatremia. And then excessive sweating, like sunstroke, heat stroke, those kinds of things, heat exhaustion, those can cause dehydration. So the key thing here is kind of that dehydration. All right, so those are the three types of hyponatremia. Now let's talk about what sodium levels, when they are low, what they do to us. So I told you guys neural stuff is the biggest thing I want you to assess when a patient has low or high sodium levels, because it's going to affect their sodium potassium pump and how they relay electrical signals from neuron to neuron and from neuron to muscle. So seizures. Seizures are very common when patients get down below about 125. Now, if you guys remember, the range is 135 to 145. If someone's at 134, probably not going to see symptoms. Probably not even going to really write home about that. But once somebody gets down into the 120s, that's when we are really, really concerned. So lower than 125 is when they are a huge seizure risk. That's a common test question on the NCLEX. This is when you'd be putting a patient on seizure precautions. really anywhere even below 130 or so, you're going to be putting them on seizure precautions. You're also going to see mental status changes like confusion or lethargy. You just want to be careful memorizing lists for the NCLEX because they might use, delirium or something, or some other word that you haven't memorized. So remain flexible. They could say delirium instead of confusion or just mental status changes in general. Those are all things you can see with sodium imbalances. You might also see some lethargy. This can come because of the sodium imbalance, but it can also come from the water imbalances that are occurring. If they aren't getting blood flow to their brain because we have pulled all the water out of the bloodstream, then they are going to a lot of times become lethargic. Stupor, and then cerebral edema is a big one. Cerebral edema is going to occur because, like I said, the party is excuse me, no longer in the blood. It is in the brain. So the water is going to go to where the party is, and we're going to cause cerebral edema. So that is why cerebral edema is so common with sodium imbalances because the party changes. The party venue has moved to the brain. And that is going to cause the increased intracranial pressure. So those two things go together. You're also going to see some musculoskeletal stuff. So you're going to see weakness because of the neuromuscular junctions. They are confused. We're not getting the impulses through that we should. You're going to see shallow respirations because you're going to weaken that diaphragm. You're going to see decreased deep tendon reflexes because, once again, we're decreasing those electrical impulses that get to our neuromuscular junctions, muscle spasms, and then we're also going to see some hypotension. We're going to weaken our the smooth muscle in our arteries, and we're losing fluid. So if at least out of the bloodstream, that fluid is going elsewhere. It's not staying in the bloodstream because the party is not there anymore. So we're going to get hypotension. This will depend, though, on the condition. If they have congestive heart failure, if they have, kidney failure, things that are making them retain water, then you would see the opposite. So it really does depend on if they have hypo or hypervolemia on whether or not they'll have that. We're also going to see hyperactive bowel sounds and abdominal cramping. Those are two things that you want to group together. They go together. Same thing with diarrhea. So diarrhea would also be included here because you're going to get more water running into the bowels because the party will also be there. The party's not in the blood, it's in the brain or it's in the bowels because there's more sodium there. And so the body's going to actually get rid of more water through the bowels because it's going to be attracted there. This often leads to a loss of appetite. When your tummy's really upset and you're crampy, you don't usually want to eat. All right, and then as far as our cardiovascular system, you're going to see, depending on where your water is, you're going to see hypo or hypervolemic signs and symptoms. If they have lost volume, we have that isotonic dehydration where we've lost sodium and water at the same rate. You're going to see weak pulses, like +1 pulses, and you're going to see a reflexive tachycardia. When we lower the blood pressure, the heart rate speeds up to try and compensate for the lack of volume. And then obviously that hypotension, and then dizziness, headaches. Those are all things you'll see with hypovolemia that comes with that hyponatremia. And then hypervolemic hyponatremia is going to cause the opposite. So bounding pulses, hypertension, things that you see with heart failure because you are, retaining all that water. All right. And then if you remember the acronym low sodium, that will help you remember some of those things I just went over. So remember levels of consciousness, orthostatic hypotension if they have low volume, weakened muscles, seizures, osmolality will be low because the blood will be more dilute. And then diarrhea, increased intracranial pressure due to the fact that we will get some cerebral edema from water rushing into the brain. High urine osmolality, though, because they will start pulling back on the urine making because the body's going to try to retain water and sodium. And so what will get peed out will be very concentrated, and then they'll have those higher or hyperactive bowel sounds. So low sodium, if you remember that acronym, you can remember quite a few of these things we went over. All right, next one. Okay, so since this is a free webinar, we can't get through without a few ads. So this is our plug for our SurePass combo. I saw several of you talk about this earlier that you're already enrolled in this. This is kind of our number one product, number one recommendation because it gives you your on-demand videos as well as QBank access and the 3-day live review. You can attend it live or you can watch the recordings. So if you're taking the RN exam, your QR code is here. If you're taking the LPN exam, your QR code is here if you guys are interested in that at all. And it is very reasonably priced and is a great, great product. But obviously, I'm a little bit biased. All right, so let's talk about treatment. When we have low sodium, we need to restore the sodium levels, right? And then usually, if we have to give water, then that will also correct things. But sometimes just correcting the sodium imbalance will draw the water back where it needs to be. So with hypovolemic hyponatremia, we are going to restore both the water and the sodium. So if it's mild, so say their sodium is 130 or a little bit above that, or, somewhere in that range, we're going to just give normal saline, just 0.9% normal saline. That is your basic NS. This is an isotonic IV fluid, which means that it stays in the blood. It doesn't go out. It doesn't cause fluid shifts, doesn't do anything. It just goes and it expands the volume. If their hyponatremia is severe, we might give a hypertonic solution like 3% NS or 5% NS. But if we do give those hypertonic solutions, you always want to be very careful about giving them very slowly on a pump at the prescribed rate. Because if you give sodium too quickly, you can actually cause cerebral edema. So when we correct these and we put too much of the party back in the blood, you can actually cause some confusion with your sodium ions. They will run to the higher concentration, but then suddenly they'll dilute it so fast that the brain will have the party again and they'll rush back to that other party and cause that brain swelling. So we never want to correct sodium imbalances, especially too quickly. And that is really true of all electrolytes. You always want to correct them slowly because if you do correct them too quickly, you will cause even more problems than you had in the first place. Hypervolemic and euvolemic hyponatremia, these are treated somewhat the same in the fact that we just need to restrict their free water. So we don't allow them just to drink, especially with water intoxication patients, we're not going to just let them keep drinking. We're going to regulate that. We can also give things like sodium tablets. This is kind of like if anybody has ever worked with cows before, you give like a salt lick. That's kind of what these are. They're just sodium tablets. And then we can also give osmotic diuretics like mannitol. Mannitol will have you get rid of just water, but the sodium will remain. So that is sometimes used, and it does it gently. So that is often used for cerebral edema type situations where we've got this hyponatremia. And then we can also encourage high sodium intake. So these are the foods that are easy to remember because they're everything that's, delicious and bad for us and processed, like hot dogs and cheese and butter and bacon, anything canned. That's a huge buzzword on the NCLEX. Anything canned is going to contain a lot of sodium. Anything that is preserved or processed is going to have a lot of sodium in it. And then obviously table salt is sodium chloride. So that is going to be something we would help these patients choose. They want those sodium containing foods. But always, always monitor neurostatus when we are giving these replacements. All right. Always replace it slowly. The rate that we replace it at is 0.5 milliequivalent per hour. So the physician, the pharmacy, they will help you calculate that in real life. On the exam, they might have you calculate things like this, but most of the time, your sodium replacement, they will say run it at 100 mils per hour or whatever it is to make sure that they get that 0.5 milliequivalent per hour. Always remember that giving it too quickly and not on a pump, can cause that increased brain swelling. All right. So, oops. All right. Next slide. So you guys can participate a little bit. I won't just talk at you for so long. What are some things that you think can cause hypernatremia? What are some things that are going to cause sodium to go up? Let me know in the Slido. Hey, good. I see diabetes insipidus. So in diabetes insipidus, it's the opposite of SIADH that we just talked about. They're going to pee out all their water, but the sodium remains. So they get high sodium levels. I also see dietary stuff. So a lot of you are saying high sodium intake. Good. So a lot of people douse their food in salt, or they eat too much processed food. Those are things that can cause hypernatremia. I see heart failure. So if heart failure causes sodium and water retention, then you can get hypernatremia. Um, let's see. Dehydration. So if you just lose water, if we just lose fluids, then your sodium can go up. Good. Um, Cushing's. So I see someone said Cushing's. You're exactly right. So Cushing's causes an increase in steroid production that causes us to retain sodium in water. And the kidney problems. Good. So when we're not filtering things out, we usually retain electrolytes. Um, and you're exactly right. Although we did talk about if you just retain more of the water and the sodium gets diluted, sometimes you can get hyponatremia, but they'll have to give you a lab value for you to know what's going on there. Okay. All right. Awesome job, guys. Great job. You don't even really need me to go through this. Sounds like you all know it. All right, so we can go a little bit faster now because we understand that there are three types of sodium imbalances on each side. So we have euvolemic hypernatremia, where the water has stayed the same, but the sodium goes up, or the water decreases slightly, but the sodium stays the same. But in either case, your volume remains normal. Your hypervolemic hypernatremia, you lose or you gain more water, but you have gained sodium at a higher rate. And then you have hypovolemic hypernatremia where you've lost the water, but the sodium remains. So euvolemic hypernatremia, this is caused by kind of rare things that cause hypernatremia, like hyperventilation, excessive sweating, fever, and then that diabetes insipidus that we talked about. If they pee out everything, but the sodium remains, you can get euvolemic hypernatremia. Now, over time, they're going to become hypovolemic. So this is not going to always stay in that euvolemic situation. Hypervolemic hypernatremia, this is when we've given too much hypertonic saline, our 3% or 5% saline, or maybe we've given too much sodium bicarbonate, sodium-containing medications, or they've increased their sodium intake, too much bacon, too much canned stuff, or they have too many steroids, like in Cushing's disease, or we've given them too many steroids, or they've been on chronic steroid use for a long time, or hyperaldosteronism, which is another part of Cushing's disease, but it can also be caused by other conditions like Conn's disease and things like that. Hypovolemic hypernatremia is going to be caused by the same things that can cause hyponatremia, but if we just lose fluid, then the sodium remains. So things like dehydration, if they aren't eating or aren't drinking, diarrhea, vomiting, burns, diuretics, those same things that can cause hyponatremia and hypovolemia here can now cause hypernatremia if the sodium stays behind. So that is where sodium gets a little bit tricky. They have to give you some lab values in order to say what is really going on. All right, so let's talk about what you see with hypernatremia. So you're going to see some very similar things to hyponatremia, unfortunately. So it's hard to differentiate sometimes. You're going to see some mental status changes for sure. We're going to see sometimes restlessness and agitation, sometimes lethargy. So it kind of really depends on the patient and their levels. You can see drowsiness, stupor, coma, and even at certain levels, you can see seizures with hypernatremia as well. So that isn't just with hypo, but that is something that we kind of associate more with hyponatremia. You're also going to see musculoskeletal stuff because of the neuromuscular junction. So twitching, cramps, weakness, all of those things. And one of the key kind of hallmark signs of hypernatremia is a low grade fever. So somewhere between, 99 to 100, maybe 101, but they shouldn't get too far above that. But we can see those low grade fevers with hypernatremia. You also see some flushing. Flushing is another kind of differentiating sign of hypernatremia, and that's because the party is in the blood, right? So the water is going to draw into the bloodstream and it's going to cause vasodilation in a lot of people. So that's where that flushing comes from. And then it depends on whether we have hypervolemic hypernatremia or hypovolemic on what our pulses will do, what our blood pressure will do. For the most part, you're usually going to have hypervolemia, hypernatremia, but it really just depends on the situation. You're also going to see decreases in urine output because the body is going to retain water to try and dilute the sodium. You're also going to see dry mouths and mucous membranes. It's kind of like if you eat too many salty chips and your saliva, gets really, it pulls water from your mucous membranes to dilute all that salt, and then you're left with a dry mouth, and the corners of your mouth get all chapped. That is what is happening here. Our body pulls water from other areas to try and dilute all their sodium. So they get dehydrated elsewhere. They often get GI problems as well, where it'll draw water out of the bowels and they can have, hypoactive bowel sounds and things like that. So if you remember fried and salted, that will be your acronym to remember with hypernatremia, that low-grade fever, the restlessness and agitation, increase in fluid retention, edema, because that fluid isn't all going to stay in the intravascular space. At some point, it will third space. Dry mouth and mucous membranes, skin flushing, altered levels of consciousness, which we kind of saw up here, low urine output, thirstiness, elevated blood pressure, decreases in energy. All right, so treatment of hypernatremia. If they have euvolemic hypernatremia, we're going to give free water to try and dilute that sodium. Oral intake is going to be better than IV because the body will flush out what it doesn't need. Hypervolemic hypernatremia, you need to find out whatever's causing it. Typically, it's some medication that we've given, or we've given too much saline, or hypertonic salines, or too many steroids. We're going to discontinue those, and then we're going to give things like diuretics to help them get rid of fluid and sodium. And then free water administration in this case as well, because we're trying to dilute the sodium, but the water will be flushed out if we don't need it. And then hypovolemic hypernatremia, we're just going to give NS, because at that point they have so much sodium in the body, even the small amount that we give in NS isn't going to raise that sodium very much. And because NS is going to be considered hypotonic because the body is in a hyperosmolar state at that point. But once again, we do all these things slowly, especially the IV corrections, because of that risk for cerebral edema. Always, always remember that. All right, so here's our first NCLEX question of the night. Go ahead and answer this one for me using this Slido QR code over here, and then I'll go over it in the next minute or so. Oh, is it not letting you guys do select all that apply? I'll have to fix that. Just pick your number one answer, or you can send me your answers in the chat if it's not letting you select all that apply. All right, I apologize about the confusion with that one. Okay, so we have hyponatremia. This is a very low sodium level. This is concerning, very concerning, because we could get seizures, and at some point this will lead to death, right? You cannot survive without enough sodium in the blood. So you guys, for the most part, have all gotten these correct. I know it would only let you choose one, so but I'm sure you guys would have chosen the correct ones if you could. So confusion is huge. Mental status changes are huge. And then abdominal cramps, because suddenly the party is no longer in the blood, the party is in the bowels, and in the brain, right? So that's where we're going to get the swelling and causing the seizures, and then the abdominal cramping and diarrhea will go along with this as well. And then nausea and vomiting. Good. You guys you grabbed that one, even though we didn't really talk about that much. Nausea and vomiting are par for the course anytime you have fluid shifts in the body. The brain does not like it when things are moving too fast. So nausea and vomiting are pretty much a side effect of any huge electrolyte imbalance. All right, and then I'm glad to see not many people chose hypoactive bowel sounds. Always remember on STATA questions not to choose things that are incompatible or opposite with each other. So you wouldn't want to choose abdominal cramps and hypoactive bowel sounds. Those wouldn't go together. You would see hyperactive bowel sounds. The test writers commonly do that. They commonly change just one prefix or suffix to make it opposite. And then tall peak T waves, we're going to talk about that when we talk about potassium. All right. Here is our next NCLEX question. Go ahead and answer this one. If it won't let you do select all that apply on this one, just choose your number one. And then you can put your answers in the chat if you'd like. All right, just a few more seconds on this one. All right. So this time we had hypernatremia, right? And you guys did great on that one. Dry mucous membranes, because the water is going to get pulled out of the mucous membranes and into the blood to try and dilute it. And then you're going to see those mental status changes that we also saw with hyponatremia. You don't see a ton of respiratory symptoms with sodium, although at very, very high and very, very low levels, you're going to start seeing some of that involvement. But for the most part, you're going to stick with musculoskeletal and neurological symptoms, as well as volume, changes with sodium. All right, great job, guys. Okay, so here's another ad here, this time for small group tutoring. We do small group tutoring nearly every day of the week. There's tons of great tutors, 25 hours a session, and this is the QR code here. All right, potassium. So let's finish up with potassium here. Potassium is the most abundant intracellular cation. So it is inside our cells mostly. With the sodium potassium pump, it leaves the cell and sodium is going to flip-flop with it, and that's how we create that electrical gradient. So it is very, very important as well in our, muscular and neuromuscular function. But what I want you to think about with potassium mainly is the heart and EKG changes. So that's where we're going to focus the most of our time here. Um, the normal value for your potassium is what is found in the blood. As I talked about earlier, there's a lot less potassium in the blood than in the cells, and a lot more sodium in the blood than in the cells. So that's why our sodium level is so high, or such a big range, and our potassium is such a low number, 3.5 to 5. And that is one I want you guys to know. But do be aware that the NCLEX does give you normal ranges now. So you don't have to be hyper fixated on remembering these, but it is still good to be aware of them. All right, so very important in our nerve impulse conduction. Always remember that our heart is a muscle, and so it's very important in the EKG and just in the electrical impulses that run through the heart, and then skeletal muscles as well. So those are where you're going to see the main signs and symptoms. Potassium is also very important in our acid-base balance, and we're not going to get too deep into the chemistry there, but if you remember that acidosis causes or is related to hyperkalemia, and alkalosis has hypokalemia, then you'll be good to go. So just remember those two things, and you'll remember what they do as far as your acid-base imbalances. All right, so let's talk about hypokalemia. So what are some causes that you guys can think of that would cause hypokalemia? So once again, thinking about gaining and retaining or losing. Are we gaining or are we losing things? All right, good. I see tons of people saying diuretics. So potassium wasting diuretics, like loop diuretics and thiazide diuretics, are going to cause hypokalemia, right? So furosemide is a loop diuretic. Good. You guys are exactly right. Um, I also see low potassium or no potassium in their diet. Awesome. Laxatives, anything that's going to make you have diarrhea or push things through, that can cause a lower electrolytes, especially potassium. Good. Um, Severe burns. So burns are a tricky one because burns can actually cause hyperkalemia. These ones are tricky. And that's because you destroy those cells, and all those cells have a ton of potassium in them, and that potassium has to go somewhere. It's the same thing with tumor lysis syndrome, if anybody's heard of that before. When the tumor gets destroyed and the potassium and phosphorus, everything that was in those cells has to go somewhere, and it goes into the blood. So those are two situations where it's kind of the opposite of what you would think, and it actually causes hyperkalemia, which we'll talk about a little bit later. All right, so I also see some steroids. So Cushing's disease can cause hypokalemia because they retain sodium in water and they lose potassium. It's due to increased aldosterone levels. So anytime you have increased aldosterone levels, increased steroids in the body, you can get low potassium levels. I see someone said alkalosis. Perfect. You are correct. We just talked about how your acid-base imbalances can cause potassium issues. So alkalosis is going to cause hypokalemia. It's kind of the chicken or the egg, which one, is causing the other, or which one comes first, but it is part of alkalosis. All right, and then someone said ACE inhibitors. ACE inhibitors are going to cause hyperkalemia. So save that thought for the next, when we get to hyperkalemia. All right, so some causes of hypokalemia. Remember the acronym DITCH. So drugs. You guys mentioned them. You guys are on the ball. Your laxatives, your potassium wasting diuretics, steroids. Not eating enough potassium. If they're NPO prior to surgery, or they have pancreatitis, or they have a poor diet, or maybe they have an eating disorder like bulimia or anorexia. Alcoholism. Alcoholism lowers all electrolytes, vitamins, and minerals because they are drinking their calories and they're severely malnourished. I do want you to remember that one for your NCLEX. You can also drink too much water and dilute your potassium, just like we talked about diluting your sodium levels. So polydipsia, water intoxication, giving too much IV fluids, you can dilute potassium. Cushing's, where we have too many steroids in the body being produced from the adrenal glands, that's going to cause us to retain sodium in water and get rid of potassium. There are also some herbal supplements that can mimic kind of your aldosterone, like licorice. Licorice is one that can cause hypokalemia. So be aware of some of those herbal supplements that can mimic these kinds of things. And then heavy fluid loss. So vomiting, diarrhea, NG tube suctioning. Those are, kind of the big three that are always going to cause lower electrolyte levels. And then wounds that are weeping and sweating and all of those things. And then alkalosis that we've talked about. And also hyperinsulinism. Some people create too much insulin, kind of like the opposite of diabetes, where and insulin shoves potassium into the cells. That is why insulin is actually a treatment for hyperkalemia, which we'll talk about here in a little bit. Insulin and sugar do help to lower potassium levels when they're high. All right. So assessment, what do we see with hyperkalemia? You're going to see decreased reflexes and weakness and flaccidity. Those kind of go together. Shallow respirations. We're going to weaken that diaphragm. Decreases in bowel sounds, constipation, abdominal distension. Those are three things I want you to link together. And then orthostatic hypotension, weak thready pulses. Those are things that go together. And cardiac dysrhythmias, EKG changes. That's where I really want you to focus most of your energy here. And if you remember the 6 L's, you'll get all those things down. Lethargy, low or shallow respirations, limp muscles, lethal dysrhythmias, leg cramps, lots of urine output. Those are the 6 L's of hypokalemia. So some EKG changes I want you guys to be aware of. With hypokalemia, the main thing I want you to pay attention to is you get this weird U wave. It's a secondary T wave. It's in between your actual T wave and your next P wave. So you're going to see like 3 waves in between your QRS complexes. You should never have a U wave. A U wave is never normal. You're also going to see flat or shallow or inverted T waves. So that is going to set you up for that U wave. And that's all due to the electrical imbalances that are happening because this electrolyte is out of whack. You're also going to see ST depression, a slightly prolonged PR interval, but you'll see those with hyperkalemia as well. So just remember that those are with potassium imbalances in general. And then you're going to see a slightly peaked P wave, which is kind of hard to pick out of a lineup if we're being honest. So the main 2 things I want you to pay attention to are the weird T waves that are flat, shallow, or inverted, and then a U wave. All right. Let's talk about what you do with hypokalemic patients. You are going to put them on telemetry, so you know what that EKG is doing. You're going to hold any medication that is going to lower the potassium further, like a loop diuretic or a thiazide diuretic. You're also going to hold a drug like digoxin. Digoxin is a cardiac glycoside, and it is very dependent on normal potassium levels. If they have low potassium, then they can get into digoxin toxicity. Can anybody tell me in the chat what digoxin toxicity causes? What are some signs and symptoms? One of the biggest things is a very distinct thing. Yes, good, Emma. Yellow-green halos. I want you guys to remember yellow-green halos. Those of you who said nausea and vomiting, also perfectly correct. It does cause nausea and vomiting. And then eventually it will cause severe bradycardia and fatal dysrhythmias like VTAC and VFib. So always hold digoxin if someone's potassium is low. And just a tip for the NCLEX, if they ask you about a medication, a specific medication, and they're asking you what electrolyte to check, typically it's going to be potassium. Potassium and pharmacology are huge. They go hand in hand. They also butt heads. So like diuretics, you're always going to check potassium. Digoxin, you're always going to check potassium. A lot of herbal supplements will mess with your potassium levels. So a lot of meds are going to require normal potassium levels. Treatment. Also, we're going to start with oral potassium first because it's the best way that the body can utilize potassium without harming it. So we increase dietary potassium, avocados, bananas, kiwis. Those have lots of potassium in them. A lot of fruits and vegetables do. And then if that's not going to work, then we're going to give oral potassium supplements. Oral potassium supplements usually come in large pills or capsules. They're hard for people to swallow and they taste disgusting. So you're going to teach patients about that. They're also really, really hard on the stomach. So give them with food. Most of our potassium comes from our food, so it doesn't matter if you give electrolytes with food. And it will help prevent the GI upset. These do cause a lot of gastroenteritis for some people. And then IV potassium supplements are the last resort because they are so hard on the veins and because they are very dangerous. Potassium supplements, if given too quickly, will stop the heart. So always, if there's only one thing you learned from me tonight, make it be this. Always give IV potassium on a pump slowly, never IV push. IV push stops the heart. All right. This is exactly what I just talked about. I forgot the slide was in here. Never give it IV push. Also, always make sure your IV is good. If your IV is bad and potassium extravasates into the tissues, it will cause severe tissue damage and necrosis even. So it's ironic because we need potassium. It's part of it's intracellular. It needs to be in our cells. But if you give too much of it and too fast or into the tissue, you can cause a lot of damage in the body. All right. And this is just a list of potassium-rich foods. remember just tons of fruits, tons of fruits. The rest of these just kind of be aware of, but tons and tons of fruits. And the big ones I want you to know, the avocados, the kiwis, the bananas. Oral potassium supplements usually have K in the name because potassium, that is the atomic symbol. They always taste disgusting and they're really hard on the stomach. And then we already talked about that. All right. This is our private tutoring page. QR code is here. Lots of great private tutors with Archer Review. This is $75 an hour. So keep that in mind. All right. We are running out of time here, so I'm going to skip over this Slido slide. I apologize, and talk about hyperkalemia. Hyperkalemia is typically caused when we destroy cells. So burns, we talked about that, or in diabetic ketoacidosis. Always remember acidosis and hyperkalemia go together. When blood sugar can't get inside the cells, then neither can potassium. So they both sit and they hang out in the blood together and they do a lot of damage. They wreak havoc. So in DKA, you get hyperkalemia and hyperglycemia. But the good news is that you can treat them both with insulin because potassium likes to go in through blood glucose channels to get to the cell. We'll talk more about that a little later if we have time. Too much total potassium, so kidney failure, if they're eating too much potassium, if they're using too many potassium supplements, or if they are using salt substitutes. So usually salt, is sodium chloride, right? But potassium can be substituted for salt. So you get potassium chloride because potassium and sodium ions are actually fairly similar, and they're both just have a positive one charge. So potassium chloride tastes identical to sodium chloride to most people. And so a salt substitute usually has potassium in it. But if patients douse their food in potassium chloride and they think they're decreasing, their salt intake, they can get hyperkalemic. Also, ACE inhibitors and ARBs, their neighbors, their sartans and the prils, those can all cause hyperkalemia because they decrease your aldosterone production through the renin-angiotensin cycle system. So these can cause hyperkalemia because of that. So always keep in mind that those two meds, you need to monitor potassium levels. And then potassium-sparing diuretics like spironolactone and eplerenone and some of those other ones, they can make you retain potassium to dangerous levels when they are used. So remember, causes of hyperkalemia, machine medications, acidosis, cellular destruction like burns or tumor lysis syndrome, hyperaldosteronism because they retain sodium and water but lose potassium. Or sorry, I said that backwards. They are going to lose sodium and water and gain potassium. Too much potassium intake, like we talked about. Renal failure because our kidneys are not filtering things out. And then excretion impaired, which would be the kidney failure. All right. Oops, too fast. Okay, I'm gonna make this quick. Assessment, muscle weakness. We saw that with hypokalemia as well. You're gonna weaken the muscles anytime your electrolytes are out of whack. Numbness, shallow respirations, cramping, hyperactive bowel sounds, and diarrhea. Those are three things we link together. Impaired contractility, so you're gonna get decreased cardiac output, which is gonna lead to decreased urine output as well, but that's later on. And then weakened pulses, bradycardia, hypotension, and then most importantly, EKG changes. The EKG changes with hyperkalemia that I want you to remember is that it makes everything bigger or taller. It stretches out your EKG. So wide flat P waves, a widened PR interval, that's basically a first degree block. We saw that with hypokalemia as well. We also see a widened QRS. We see a tall peaked T wave that's even taller than our QRS, and you see a depressed ST segment, which we saw with hypokalemia. So everything's wider or taller, except for that depressed ST. So that's the black sheep. Both hypo and hyperkalemia are going to eventually lead to worsening heart blocks because they already cause a first degree right here. So it can become a second or a third degree heart block, and then eventually VTAC, VFib, and asystole. So you do not want your potassium levels to be out of whack. You want these patients to be on telemetry. You want to be monitoring them closely. So treatment, telemetry, You're going to discontinue any potassium supplements or any IV fluid that has potassium in it, even in small amounts. You're going to restrict the potassium. We give IV calcium gluconate. This is kind of counterintuitive because why are we giving calcium? It doesn't lower the potassium. All it does is it protects the heart. It bolsters up the calcium levels, calcium channels. It does not let the potassium have its way. So it bolsters up the heart. We give medications that drive potassium into the cells. So I've already talked about insulin. Insulin opens up those blood glucose channels. Potassium can rush in through those channels and get in the cells. So insulin drives that into the cells. You can't just give insulin by itself, though, because that would bottom out their blood sugars. So they have to give some sugar, D5. Albuterol is also a treatment. It is not just a bronchodilator or beta adrenergic. It also shoves potassium into the cell. It's part of the fight or flight mechanism. But just keep in mind, albuterol is used for more than just asthma and bronchodilation. It can be used for hyperkalemia. And then bicarbonate. Bicarbonate is going to treat the acidosis that's going to go hand in hand with the hyperkalemia, and it also pushes the potassium into the cell. We can also give medications that force potassium out. So Kxalate, this basically gives them eternal diarrhea. It's one of my least favorite medications ever to give. And diarrhea makes you lose electrolytes. So that's how that works. It also has a few other functions, but that's the main gist of it. Diuretics. You are going to give loop diuretics and thiazide diuretics this time to get rid of potassium using those potassium wasting properties. And then when nothing else has worked and we only have, one more resort, we're going to go for dialysis and actually, pretty much physically pull that potassium out. So that is how we do this. We always start with the least invasive things and then we move onward. All right, if you remember the acronym CRIDE, you can remember that we give calcium gluconate, we remove all sources of potassium, we increase the excretion and the uptake into the cells, and then last resort, we do dialysis. So CRIDE is how we treat hyperkalemia. All right, I'm going to end with this question here, so go ahead and answer this last question, and then we're going to get to bed or let you guys get to bed, depending on, what time it is in the world where you're at. But go ahead and answer this question, and then we'll go over it quickly. All right, just a few more seconds on this one. And if Slido isn't letting you do SATA, just either put them in the chat or just say it out loud, or write it down at home. All right. Okay, so we have hyperkalemia. It's above 5, and we're expecting to see everything wider or taller, right? So tall peak T waves, widened QRSs. We wouldn't want to choose tall peak T waves at the same time we choose inverted T waves because you can't have both. And the inverted T waves and the U waves, those are things you see with hypokalemia. So they were trying to trick us with those two answers. And then if this had said more than 0.2 seconds, that would be correct. Always remember that a PR interval should be less than 2/10 of a second. All right. Okay, we will end for the night there. I appreciate all of you guys joining our free webinar. I apologize for going over by a few minutes. A big thank you to Jennifer for fielding all your questions in the Q&A and keeping on top of that because I certainly couldn't do it myself. All right, so always remember, use all your resources at Archer Review. All of the products that we have are designed to help you and to be cost effective. We're in your corner. We want to make sure you guys all pass. We are all nurses. We know how short-staffed our departments are. We need you guys. We need you so, so, so badly. All right, so we want to help you pass this on this first attempt or the next attempt, no matter how many times you've taken it. All right. I will let you guys go. Have a great night. Thank you guys again, and a big thank you to Jennifer. Good night, everybody.